Hello, friends. So I'll be talking on this topic ECMO in trauma. So this talk I gave on 6th April 2024 in Narayana Hrudyalaya ECMO workshop. I wish to acknowledge my colleague, Dr. Pratibha, who helped me develop this content. So I'm sure ECMO is something which everyone has started using. So the indications are getting broader and broader, and one is doing ECMO for various other conditions. So in this particular talk, we would review as to whether ECMO has any role in trauma and whether there are reasonably good sort of studies or scientific data to substantiate its usage in trauma. So the topics I would cover is a bit of a background. So what are the indications and contraindications of ECMO in specific to trauma? And is there a role of ECMO as a bridging strategy in trauma? And we'll look into some contraindications. Most importantly, clinical studies, just at the outset, so there are no major randomized, you wouldn't expect obviously randomized trials or big studies. Most of the literature comes from case series, anecdotal case reports, and there is one meta-analysis which I will take you through. And it's important to have some clarity on timing of ECMO in trauma and what are the anticoagulation choices that we have, because that is another big dimension when we're talking about ECMO. And then we'll just conclude with some take-home messages. So when you look at this picture, so this was the first ECMO that happened in the world way back in 1972, 1974. And this happened in a trauma patient. So the whole journey of ECMO started with a trauma patient. And this is ECMO trauma patient way back in 1971, sorry. So this was a 24-year-old male who had a road traffic accident with a rupture of aorta in 1971, went on to develop ARDS, and it was Dr. J.D. Hill who put this patient on an ECMO. And this patient was on ECMO for 75 hours, after which he was decannulated, and patient survived miraculously way back in 1971. So the whole saga of trauma dates back to close to 50 years. And the whole journey started with the trauma. So that's the historical backdrop of this. So when we talk about indications of ECMO and contraindications, so the literature, as I said, is very scant. And just for the benefit of our listeners, there are around 36 reports. So there are 36 sort of a case series, case reports, anecdotal reports published. And that's the data at this point of time we have. But there are no big sort of a trials. There's one meta-analysis. And the indication has to be determined case to case, and it is highly individualized, and it has to be calibrated to the patient's needs, and it has to be personalized. So there is no sort of a sacrosanct rule as to, okay, these are the patients which should go take ECMO. Most importantly, when we are dealing with trauma patient, one has to do the risk benefit assessment, and the benefit should outweigh the risk when you are contemplating on putting these patients on ECMO. And most importantly, the decision to put a patient on ECMO, most specifically in trauma, has to be multidisciplinary effort in consensus with surgeons and the treating teams, because there would be various surgeons that may be involved or neurosurgeons that may be involved, and the intensivists and so on and so forth. So this is some of the things that needs to be kept in mind when initiating ECMO. When we talk about these sort of indications from where 36 reports have come out, the indications are mainly where trauma patients going on to develop ARDS. So it may be due to transfusion because polytrauma patients get a lot of blood transfusions, or ventilator-induced lung injury on ARDS. So these are the typical sort of reasons that they can have, they need ECMO. Or it can be pulmonary hemorrhage because of the injury to the lungs, or in a polytrauma situation. Very often they would have lung contusion, lung hemorrhage, and that may be one of the indication for ECMO. And lung contusions where there are blunt sort of an injury to the lung, and aspiration of whatever. So aspiration leading to ARDS is another common reason why ECMO may have to be initiated. Or in trauma patients, they are at a risk of massive pulmonary thromboembolism. And most importantly, you would know in polytrauma patient with long bone fracture, there is a risk of fat embolism. So the fat embolism also is one of the indication what one could contemplate on ECMO. Or following major sort of a lung surgeries or pneumonectomy and so on and so forth as a post-surgical sort of a respiratory failure, so one could contemplate. So these are the typical indications for which ECMO has been initiated in trauma. And how about ECMO as a bridging strategy in trauma? So ECMO has been used as a bridging strategy, especially in a major airway traumas or in patients with a papillary muscle rupture following acute papillary muscle rupture following trauma or myocardial contusion or major bronchopulmonary fistula due to lung contusions and pneumothorax that patient may have had. And as a adjunct to damage control resuscitation that happens where there is a lot of hemodynamic compromise, and VA ECMO is something that has been used as an adjunct to damage control resuscitation. So these are some of the indications where ECMO has been used as a bridging strategy. So we spoke about indications. So indications is pretty straightforward. Most of the indications are to do with the lung injury leading to ARDS. Bridging is some of the airway injury and papillary muscle, bronchopleural, and BCR. So what about contraindications? Contraindications are fairly relative. So absolute contraindications is where there is a possible imminent death and where for certain it is known that the recoverable chances is very less or terminal malignancy is postulated as contraindication. Relative contraindication is someone who is ventilated for more than 7 days after trauma, or someone who's come post trauma with multi organ dysfunction. And relative contraindication is intolerance to anticoagulation because most of these patients may need some sort of anticoagulation. But I'll talk towards the end of the talk as to how there is de emphasis now that ECMO can happen even without anticoagulation in a heparin bound circuit. So we'll just talk very briefly on that. So these are some of the contraindications which are fairly straightforward and intuitive for most of the listeners. And the lethal triad is something that happens in trauma, which is hypothermia, acidosis, and coagulopathy. So ECMO is shown to limit this worsening or perpetuation of this lethal triad and may even aid in reversing the lethal triad has been shown. So that's about the bit of a background, bit of indications, bit of contraindications. So let's look into what are the studies that are available. As I said, there are 36 studies. Obviously, we can't talk about all the studies. We'll just pick up some of the bigger case series. So this study, the use of ECMO in blunt thoracic trauma, this came from the US. Study of the ECMO database came in 2015. So they took patients from 1998 to 2014. 85 patients were reviewed who went on to needing ECMO. So the mean age of the patients needing ECMO, these are all trauma patients, was 28. So young age group, possibly all road traffic accidents, and predominantly 83.5% of them were males. And pre-ECMO, PaO2, FiO2 was 59.7 plus or minus, and the duration of ventilation prior to ECMO was around 2 to 3 days, 94 hours plus or minus 13.2. And 63 patients who went on ECMO. So the duration of ECMO was 207 hours, plus or minus 23.8 hours. And the bleeding happened in 29.4% of these patients. And out of this bleeding, 12 of these patients, 14.1% had some sort of a surgical procedure done. And the bleeding happened more at the surgical sites. 14.1 had bleeding at surgical site. Six of them had bleeding at the cannula site. So the approximate sort of a bleeding risk was around close to 30% in this case series. But this is important. Survival in the major thoracic trauma who went on to needing ECMO, survival was very respectable at 75%. So this is the take home from this study that survival was good in patients with blunt chest trauma needing ECMO. Survival was up to 75% and the bleeding risk was around 30%. Most of them happened at the surgical site of cannula site. And the predictors of survival was shorter duration of ECMO and VV ECMO as opposed to VA ECMO. So that was the salient points of this case series that came out. Okay, so 75% is a ballpark figure you can keep in mind. 30% was the risk of bleeding you can keep in back of mind. So this was another study which came from Germany. Extracorporeal lung support in trauma patients with severe chest injury and acute lung failure. It's a 10-year sort of a review. So they took patients with polytrauma. ALF is acute lung failure and they took this data of these patients over 10 years from April 2002 to April 2012. They took 52 patients. So mean age in the last study you saw it was much lesser, around 28. Here it's 32. 49 were males, 3 were females. So the most common cause of these in trauma was road traffic accident in 73%, and 17% were blast injury. Deep fall was 8, blunt trauma was. So they had all sorts of trauma. and the mean injury severity score was 58.9. So just keep that number in mind, because I would at the end of it, you would see which are the patients which benefit from ECMO. More than injury severity of more than 35, one should sort of contemplate. Here it was very severe injury patients that taken 58.9, and the mean injury lung score was 3.3 plus or minus zero point 0.6, and so far was 10.5. So these were all reasonably sicker patients who went on to needing ECMO. So when you look at the results, so here they did, as it is an old study, they did two types of extracorporeal. So PECLA is a pumpless extracorporeal life assist, and VV ECMO, which we all know, which we are doing. So 26 patients were put on pumpless extracorporeal life assist, and 26 went on VV ECMO. And the time lag for initiating VV ECMO was 5.2 plus or minus 7.7 days. And the duration the patients were on VV ECMO in this trauma series from Germany was 6.9 plus or minus 3.6 days. So 52 patients went on ECMO. Cannula complication happened in 15%, and five patients had complications in pumpless and three in the VV ECMO. And 85% of the patients in this study group underwent some sort of a surgery. And again, you see, the last study from US showed survival of 75%. In this German case series, the survival was 79%, which again goes on to show that the survival rate in patients who would be put on ECMO in severe injury with a severe injury severity score has been respectable at 75 to 79%. And if you look at the injury severity score mortality, if you correlate the injury severity score these patients had and to the mortality, it was 59%. But by putting them on ECMO, the mortality was only 21%. So that is the statement that came out of this paper, that you could reduce the mortality, because the predicted mortality was 59% as per the injury severity, but with ECMO it was brought down to 21%, is what you can keep in mind. So this was also, so both were similar. The US study 75% survival, German study 79. So let's look into the meta-analysis which came from Chinese. This is the latest meta-analysis, ECMO in adult patients with severe, 2023 it came. So as it took all the studies, as I said, there are 36 observational studies, 1,822 patients. And in this, all the studies you put together, 36, the overall survival was pretty good, reasonable, and respectable at 65.9%. And here they did a subgroup analysis, and they took only patients with traumatic brain injury. There were 16 studies which looked only into traumatic brain injury with 383 patients. Even there, the survival was pretty good at 66.1. And non-traumatic brain injury, there were 15 studies with 262 patients. Even there, the survival was 68.1%. So this is very important. So for all the listeners, the sort of survival in severe trauma put on ECMO has been good at around 65 to 69% is what you can keep in mind. With VA ECMO, when they looked at the subgroup of VA ECMO, 15 studies had patients on VA ECMO. You see the survival is very less, 39%. But with VV ECMO, which in 23 studies, the survival was 72.3%. So there was a statistically significant difference in the outcome between VA ECMO and VV, which we all know. VA ECMO outcomes are usually bad because you are doing, we know, arterial, where you do a central cannulation, the morbidity and mortality risk is generally tend to be higher. So it was reflected in trauma patients also. So our preference should be more for VV and more for lung conditions where the survival is much better. So just to show, so there was no major difference in survival between the Asian group and the European or North American. So it pretty much was uniform between Asian, European, and so there was no demographic difference. And even there was no major difference between TBI and non-TBI. The only difference is VV ECMO patients did better as opposed to VA ECMO, which we all know even in other subgroup of patients. So the conclusions from this meta-analysis, which is the largest to date, 36 studies, 1,800 odd patients. ECMO was found to be beneficial in severe trauma, and it helped improve prognosis by effective management of cardiorespiratory failure, effective management of cardiac arrest, and effective management of hemorrhagic shock. So ECMO was helpful in circumventing all these sentinel sort of events. So now we'll slowly move to what should be the timing of ECMO in trauma. So like any other intervention, timing should be as soon as possible and not to delay. So we refer to ENSO guidelines. The ENSO guidelines does not come with specific guidelines for timing of ECMO in trauma. Best results in the studies have shown to be in patients where ECMO was initiated early on within 24 to 48 hours, but there are no clinical trials comparing early versus late sort of an ECMO initiation. And again, so whenever one is initiating ECMO, as I already mentioned, the benefit has to weigh down the risk, and there has to be risk benefit sort of an assessment, and one should be able to gain more benefit than the risk is what one needs to keep in mind. So slowly we'll meander to the anticoagulation, which is terribly important in ECMO, and what is the because that is something we dread in trauma patients. The risk of bleeding increases because we have to use heparin for these patients. And what are the anticoagulation choices in trauma? So the antithrombin treatment, obviously in trauma, since the risk of bleeding is high, one has to have a good sort of a balance between the anticoagulation and the bleeding risk that the patient would have. So the recommended one, which is traditionally and even now used in ECMO, is unfractionated heparin. So unfractionated heparin inhibits the thrombin, which is already formed, but does not prevent thrombin formation. It inhibits the thrombin that is already formed, and but it does not inhibit the binding of thrombin to the fibrin. And the heparin that is suggested usually is 50 to 100 units per kg, and we titrate it to ACT, active clotting time of 180 to 220 seconds, and then we give it as an infusion at 20 to 50 units per kg per hour. But also suggests to underwhelm this dosage to much lower, especially when the risk of bleeding is higher, to 7.5 to 20 units. So if it is so 20 units per kg. So if it is 60 kg, so it would come to around 1000 units per hour is what one could decipher. So 50 to 100 units per kg as a bolus, followed by 20 to 50. In trauma, where the risk of bleeding is high, you can underwhelm the dose to 7.5 to 20 units per kg per hour. So what about the anticoagulation? The newer anticoagulation. So heparin remains the sort of a run-of-the-mill standard one that is used. But when it comes to other newer anticoagulation, there are direct thrombin inhibitors, which is also postulated to be beneficial. The ones that are currently available as IV formulations are argatroban, bivalirudin, and lepiridine. The most commonly studied is argatroban. So dabigatran is the oral. So these are the IV formulation. So again, to just to show, so this is the thrombin and the heparin binds to the site and it binds to the fibrin to form the clot. So the direct thrombin inhibitors bind to this active site that is present and it reduces the generation of thrombin. As I said, the unfractionated heparin inhibits the thrombin that is already formed and does not prevent the formation of thrombin. But here, the direct thrombin inhibitors has shown to reduce the generation of thrombin, and the risk of bleeding was shown to be little lesser in direct thrombin. And there is no risk of heparin-induced thrombocytopenia because unfractionated heparin there is a risk of causing hits. And it is shown to have more predictable pharmacokinetics. And the direct thrombin inhibitors have shorter half-life. And but the reversal of these direct thrombin inhibitors is problematic. So these are some of the features. So as I said, the only difference is unfractionated heparin inhibits already formed thrombin, but here this may have an additional benefit of reducing the generation of thrombin, and it has predictable pharmacokinetics and it has a shorter half-life, but reversal is a problem is this. So the dose of ergotrobon is zero point 0.5 to 1 micrograms per kg per minute to target APTT at 1.5 to 2.5 times the baseline. So this is the newer anticoagulant which could be considered in trauma. So how about monitoring? So as I said, ACT is the standard sort of a monitoring, but when we are using direct thrombin inhibitor, ACT has to be combined with anti-factor 10A levels or APTT or with TEG and ROTEM. So now in this day and age, there is an emphasis that possibly one can perform ECMO without the need of these anticoagulation or antithrombin agents because of the centrifugal pump and heparin coated circuits. By using heparin coated circuits, and all the modern ECMO machines work on centrifugal pump. So there is a hypothesis that one can perform ECMO safely in a situation where the risk of bleeding is high without the use of heparin. I think this is the sort of ideation that is happening. And heparin-free ECMO has shown to have reasonably good outcome with reduced complications. So now the question is, are there studies to tell us that one can use heparin-free ECMO in a safe way and shown outcome? Yes, there are anecdotal or case reports. So this is one of the studies that came, or observational sort of a study which came from Germany. Prolonged heparin-free extracorporeal ECMO in multiple injured acute respiratory with traumatic brain injury. In this particular sort of observational study, there was no major complications by using heparin-free ECMO. And this was another study which came from Taiwan, where they used non-heparinized ECMO, serves a rescue method in multi-trauma patients with pulmonary contusion. In this study also, there was no bleeding or clotting complications that happened in patients who were put on ECMO without heparin. So that's about the new sort of an ideation that is happening, that we can, if the risk of bleeding is touted to be high, one can safely consider doing ECMO with a heparin coated sort of a circuits with a centrifugal pump, and even heparin can be avoided if the risk of bleeding is outweighing the benefit from ECMO. So this is just a flow chart as to how we can approach trauma patients in determining who should go on ECMO. So if you have a trauma patient with ARDS, PaO2 FiO2 less than 150, you have used all your ArtsNet with low tidal volume, PEEP optimization, prone, and your PaO2 by FiO2, this is like a Murray score or Eolia criteria. PaO2 FiO2 is less than 70 for more than 3 hours, which is typically a Eolia criteria, or less than 100 for more than 6 hours, and uh, mean airway pressure is more than 65, then VV ECMO could be considered. And if this patient has traumatic brain injury, one can consider heparin-free ECMO. So this is the sort of flow chart you can adopt. If PaO2 effort is more than 70, but pH is less than 7.2 and P-plat is more than 28, one could consider ECOR, which is extracorporeal carbon dioxide removal. So this is the sort of a rough flow chart that you can have in mind in determining which patients of trauma possibly will need ECMO. So how about prognosis? So this is important. As I said, the injury severity score in the German case series or observational study was 58. So the sort of submission from all the studies is, if injury severity score is more than 35 plus VA ECMO is put in, with an independent predictor of hospital mortality. But if it is more than 35 and VV ECMO is has to be put in, that could be considered as something which is an option. And pre-ECMO APTT more than 40 seconds has shown to be independent predictor of mortality. So the bottom line is, ECMO, from whatever evidence until now we have from 36 observational studies, is a useful strategy, especially if injury severity score is less than 35. With heparin minimized protocol is something that you can adopt, where you use a very low dose heparin infusion at around 7 to 20 units per kg per hour, or heparin circuits with a centrifugal pump also can suffice and can have a predictable sort of an outcome. So that's about the whole thing. So thank you, and also keep ECMO in back of your mind, even in severe trauma, if especially if your injury severity score is around 35, and heparin or anticoagulation is not something which should be a limiting factor for you not to initiate ECMO, is a take-home message. So request all our listeners to attend to our signature event, Global Intensive Care, that's happening on 17th to 18th October in Bangalore. So request all of you to attend and make it into a grand success. So request all listeners to submit your valuable work to our Journal of Acute Care. So thank you, and all.